Hi everyone, this is going to be chapter 2 for HSMP 5050. This is Healthcare Accounting and Finance. In this chapter we're going to cover the financial environment, so we'll go ahead and dive right into that. So when we start talking about healthcare, in chapter 1 we talked more about the background and kind of lay the foundation for some different concepts that we're going to be discussing throughout the semester, and we're trying to give you the kind of that foundational background into healthcare finance and different aspects that we need to look at and kind of be cognizant of. So when we start talking about the financial environment here, we know that the field of healthcare finance is really shaped and formed by the environment and particularly the financial environment in which we practice healthcare finance. So what we're going to be going through in this particular chapter and through this particular section is just focusing on business organizations, their goals, taxes, talking about some third-party payers, and then get into some different types of reimbursement methods. So we'll go ahead and get started. Just like I do with every lecture, I like to put the objective up here first so you can kind of see how everything ties back. But I won't go over it every time, so feel free to look at that at your leisure. But what I do go over and every time, and what I always try to start off with is some type of agenda so that you as a student can kind of put your mind around or wrap your mind around some different concepts that we're going to be thinking about and talking about throughout the lecture today. So today you can see we're going to be talking about insurance concepts, again, some reimbursement methods. We'll talk about capitation. We'll talk about fee for service. We'll get into a little bit of managed care regarding HMOs, PPOs, and the difference between all of those. We'll touch on some different coding aspects, and then we'll talk about health insurance and reform. So the first thing we're going to talk about just different types of insurance and really the concept of insurance itself. So when we think about insurance and how it functions and what you know about insurance, for insurance to really quote unquote work, we have to have a couple things happen. And this is true no matter whether you have health insurance, you have car insurance for your car, any kind of insurance that you have. So we have to have, really this pooling of losses that comes together. We're kind of pulling together to kind of identify what the payment would be out on any losses that we may experience. That we only pay out for those random losses, and we can have some certain type of risk transfer, and that we have some type of indemnification. And if you're unfamiliar with that term, what it really means to indemnify is really to compensate for a loss or damage. So you're getting some type of compensation out of a loss or a damage that you experience, and it's really works to provide some certain type of level of security for financial reimbursement to you as the subscriber and to you as the person paying for this insurance in the case that you have this really specified loss. So when we have health insurance, we can term, our loss or damage as, I have to go to the doctor, so that's going to be my quote-unquote loss. So health insurance is going to step in and help pay for that component. But two main problems really come about when you sit and really think about health insurance and how it works, or when you think about insurance in general, but especially about health insurance. There's two main problems that we see kind of arise out of the concept of insurance and health insurance in particular. And that's going to be adverse selection and moral hazard. And we'll get into those a little bit more in depth here in the next couple slides. But I wanted to go ahead and present those terms so that you can be thinking about them. And when we get to them, like I said, we'll cover those a little bit more in depth here in the next couple slides. So we have two positions when it comes to how we write insurance out. And this is in regards in particular to health insurance. So there's two different ways you can go about obtaining health insurance out in the healthcare marketplace. So the first way is your community rating. So you have everyone buys into this type of group type insurance where, let's take, for example, I as a state employee working for the university, we have group insurance. Most states have their insurance set up that way. So state employees buy into this insurance and we all pay the same premium for everyone. There's a couple exceptions for like if you smoke or have some type of tobacco use, but generally with the community rating, we all, everybody who works here at the university and has insurance through the university, we are all going to pay the same amount for insurance. I'm going to pay the same as anyone else in my department or anyone else that works for the university. So that's the first type of position that you can have regarding insurance and group insurance and self-insurance, where everyone kind of pays the same or similar rate. So the next view on that is how it used to be when before we had the Marketplace and the Affordable Care Act, we had individual private insurance that was based on an experience rating. And in experience rating, really the individual or the person makes the determination of what their premium is going to be. The issue with this is that the experience rating has the potential to really cause around a 17-fold difference in the cost of plans. So a good example is you may have a $1,000 premium plan in a state like Texas, but that same plan could cost you $17,000 in premium upwards in the Northeast, just based on where you live throughout the country. It's really based on your experience. That's why it's called an experience rating. So another factor that works into this experience rating is your health status. That was another big determining factor when it comes to set your insurance rate. So parents, parents of children with maybe an autoimmune disease, or let's say we have a breast cancer survivor who's overweight and they smoke, they could have a $1,600 a month premium that they have to pay out because of their experience rating. You have pre-existing conditions, you're overweight, you smoke, you have tobacco use. And so that plan could cost that person $1,600 a month, whereas, a relatively healthy person, I like to consider myself relatively healthy, I could go out and get the same plan for about half that rate, between about $500 and $600 a month. So this is how it used to be before the Affordable Care Act. Now, under the Affordable Care Act, things have changed a little. You cannot deny coverage any longer for pre-existing conditions. Many insurance companies have pre-existing condition clauses in their insurance policies, and that's pretty much banned under the Affordable Care Act now. So we've moved to more of a community type rating for Affordable Care Act insurance plans that you can purchase out on the marketplace. So this is kind of what it looks like, how it's progressed from experience into community, and why it was really unaffordable, and one of the main reasons that brought around the Affordable Care Act. Because, we would hear insurance is unaffordable, we need to make it affordable, so how do we do this? And it's by pushing people more into this community rating. So under experience rating, you can see we have 3 different category pools. We've got low risk, moderate risk, and high risk. And you can see the dollar sign, the dollar amount associated with each of those. You can expect, low risk, more like you, the student, the average student, very low risk. Moderate, that would be, I would probably fall in this category. I'm middle aged with children. So I'm going to pay a little bit more than somebody that's maybe lower risk. And then you have your high risk, which is going to have a quite significant more amount to pay for insurance. High risk is going to be more like your elderly or geriatric population, which, eventually, hopefully, will all live long lives and end up here. But eventually we would all be in the high risk pool. So traditionally, before the ACA, the Affordable Care Act came into play, you would see premiums go up because generally under high risk, everyone is sicker. They have more comorbidities. They have a lot more things going on with them. that they would just have to pay a lot more. And so what we would see here in the high risk pool is that participants would drop out because of the expense. Well, what happens when participants drop out to the other participants that are in the high risk pool? So there's less people to spread that amount around amongst. So the people left, their premiums would go up, which would cause more people to drop out, which would cause premiums to go up again. So it was just kind of this domino effect that we saw, which was one of the driving forces behind bringing around the way the Affordable Care Act was designed. So how it would happen is you would pick the plan based on what you needed at the time. So you could pick a plan that has very low premiums, very high deductibles. You just pick the plan that fits where you are in life at the time. And like I said, students probably here low risk, moderate. This would be, my category, middle-aged with children, and then your higher risk, those with more comorbidities, elderly population. But now we have the Affordable Care Act as of right now, and it says out in the marketplace where you can go purchase these insurance plans, but all plans have to use this community rating scheme. So premiums are going to be decreased and shift more towards the middle. So the low risk folks here, they're going to end up paying more to offset the high risk. And it's the only way this scheme really works if we have the low risk people participating in the marketplace, and that's the reason that we have the mandate in the individual mandate saying that everyone has to go out and buy healthcare insurance now. So we're trying to get a lot more people to participate in this low risk, or from this low risk category. We're trying to get a lot more people to participate and work in this community rating standard plan setup. And you can see the cost here is trying to spread out between these three categories. So low risk are going to pay more, high risk are going to pay a little bit less, and then moderate still right there in the middle. So, but think about how we pick out insurance. So we pick out insurance based on what we need, right? So insurance was chosen by the individual based on what their anticipated need is. If I don't go to the doctor a lot, if I am very fit and healthy, don't have a lot of need for a lot of medical type services, I'm probably going to choose a plan with very, very, very low premiums and probably very, very, very high deductibles, because the chance that I'm going to use that insurance is very low. So I don't want to be paying for a lot of stuff that I'm not going to use. So we have a little bit of adverse selection going on here. And it comes about just because we do pick insurance based on what our anticipated need is, but we have some asymmetric information within the marketplace. We as people who are going out to be insured have a better knowledge of our health than those that are going to be insuring us. So the insurer, the third-party insurance company, has a little more difficult time identifying what that risk pool is going to look like amongst the people who buy into the insurance plan. And this was all happening pre-ACA, so this was before the Affordable Care Act came into play. So what that caused is we're going to have more high-risk users in the same pool as maybe our low risk, as our middle risk, which caused a problem. So we have a high risk who uses a lot of services, which is going to cause the premiums to come up because we have to compensate for the amount of services that they're using. So we had these income-sensitive populations start to drop out. They're very sensitive to how much they're paying. If they can't afford it, they're just going to drop the insurance, which, like we just said, would cause premiums to rise again and again. We can't spread the risk around. And so these are all factors that led to the formation of the Affordable Care Act to kind of even the playing field and set everybody on an even keel so that we can make this mandatory health insurance mandate work for the population at large. Now, where the point of contention comes in is more towards those low-risk individuals who either were buying very, very low premium plans or not even buying plans at all, now they are required to buy into this insurance so that we can have this community rating scheme that we talked about. Let's back up a slide that we talked about on the previous slide. And to make this work, we have to have a lot of low risk people participating in the pool to compensate for the amount of services that are going to be used by the high risk population. So this is why when we were at the experience rating scheme, this is why insurers tended to avoid the more high-risk individuals, simply because they use a lot more insurance services. They use a lot more healthcare services, so they're going to be a little more costly. And insurance, just like healthcare, like we talked about, is a business. So they're making decisions to support their business operations. So we talked about adverse selection, and we said, there were two reasons that kind of pushed us more towards the formation of the Affordable Care Act. The other one is moral hazard. Now, if you've never heard of moral hazard or how it's led to market imperfection, moral hazard really extends from we overuse health services, or we're really foregoing prevention because we as the insured do not really bear the full cost of the consequences. So what I mean by that is if we have more of it, we're going to use it, right? Especially if we're not paying the full cost. So we have health insurance. We don't know what the true cost is. I just paid a bill for my daughter for her annual checkup. It was about $15. I mean, that's not going to hit my pocket too much, but I don't know what the full cost of that service is. So I'm going to be more apt to go in more and more and more and more because I have a little bit of moral hazard happening here because I don't know the full cost of the services. Now, if I was, self-insured or without insurance and I was having to bear the full cost, I probably would be a little more cognizant of how much or how often we're going to the doctor. But how this creates this market imperfection, how we kind of got to where we are at with comorbidities, we're seeing a lot more acute, little acute, more chronic cases come in, is because, again, going back to moral hazard, individuals would have diseases, some type of disease that in the early stages would be very simplistic to take care of, because they either didn't have the right amount of insurance or they didn't have insurance, they didn't seek out health care, so they waited until it got to a point where now we're having to administer emergency services to these individuals because the disease progression has gotten to the point where it needs a lot more intervention. So some mechanisms that have been put in place to address this issue that's come out of moral hazard, if you have insurance, you're familiar, you have a deductible, you have a copay, you have co-insurance, there's stop-loss limits, and we have some policy restrictions in regards to your health insurance, and we'll talk more about those throughout the lecture today. So when we talk about third-party payers, we have two main types. We have private and we have public. And we'll go over examples of each and talk a little bit more about private insurers and public insurers. But for the most part, when we consider healthcare services, we're not paying everything completely out of pocket. We've got some type of insurance mechanism in the works there. And those come in the form of our private insurance and then our public, more public or government type insurance companies. So let's see, when we start talking about private insurers, this is the one that everyone is probably the most familiar with or you can relate to the most, just because this is the insurance that you get through work. It's employer bought. You can have employer bought, where, when you go to work, one of the benefits of working there is being able to tap into the insurance that they have available that you can purchase into. You can have commercial insurers like Humana and United Health that offer plans out in the marketplace that you as an individual can go out and buy. And the commercial insurers are more along the lines of those companies that they issue health insurance plans and are typically issued by like life insurance companies, casualty insurance companies, or companies that were formed to really write health insurance in particular. And again, examples of those would be Humana and United Health would be really good examples of commercial insurers. And then the third one you have is a self-insurer. And what is an example of this? So an example of a self-insured health type insurance is Eastman right here in the Tri-Cities. So for example, Eastman, they're going to go out and hire a third-party administrator to manage claims. But they, the company bears the risk. They've set aside a fund to pay for the cost. They work just like an insurance company, but they keep everything in-house. So those companies that really choose to be self-insurers make the decision to bear the risk, as I mentioned, that are associated with healthcare costs, and then they set aside the funds to pay for those future costs that may occur from the subscribers that they have in the plan. So those are three types of private insurers that hopefully everyone's familiar with. Hopefully you went over this in other classes, or you're familiar with it through your work, or because you've had to go out and buy insurance yourself before. So what we'll talk about now is the other side of that, which is public insurers. The first one that I want to focus on, and I know you've probably heard this a lot in your other classes, but is Medicare. Medicare is a federal, United States federal health care program that works to subsidize people who meet one of the following criteria. So you can be an individual who's 65 or older. You have to be a U.S. citizen or permanent legal resident for about 5 years to qualify for Medicare. You can be disabled and but you have to collect Social Security for a minimum of 2 years to qualify under that criteria. Or you have to be undergoing dialysis for kidney failure or a kidney transplant, or you're in end-stage renal disease. So those are the three criteria to qualify for Medicare. You have to be 65 plus, disabled, or end-stage renal disease type of kidney failure or kidney transplant. Now there are 4 parts to Medicare. Hopefully everyone's familiar with this. This is A, B, C, and D. So Part A encompasses inpatient hospitals. They encompass skilled nursing facilities, home health and hospice care. So all of your major hospitals like your Johnson City Medical Center, your skilled nursing facilities, and any home health services or hospice end-of-life type care is covered under Part A, or concerns with Part A. Medicare Part B are generally all the other necessary medical services that you'll need to get throughout your lifespan. So these are like your doctor's services, labs that you need done, x-ray services, your wheelchairs, different types of medical equipment qualify for this. So that will all fall under Part B. Now, Part C is the Medicare managed care, and it's managed care that's offered by private insurances. So it's supplemental to what you get with Medicare, and you can buy Part C plans. And then Part D is probably the newest component to the Medicare setup, but Part D works to cover prescription drug costs. So to the other side of Medicare, which is administered by the Center for Medicare Medicaid Services, is going to be Medicaid. Now, this is a little different than Medicare, where it's a joint federal and state program. You have to be low income, so there are some qualifications that you have to meet. You have to be low income. You have to be medically indigent. It's funded by the federal government, but it's ran by the state. Like I said, it's a joint federal and state program. And because it's a joint funded federal and state program, the federal government will give matching dollars to what the state will make available. Now, because it is ran by the state, it is subject to change coverage between states. So, TennCare, which is Tennessee's Medicaid program here in Tennessee, is not going to be ran the same way as the Medicaid program offered in a state like Arizona, California, things like that, because it is up to the states how they want to run their Medicaid programs. But the federal government, like I said, they do give matching funds to the state. So before we move on, I've got a short video, if I can get it to work, and I'll also post this on D2L, that'll go over a couple of components that we're going to talk about in regards to health insurance coverage. But this is going to give you the basics. I like this video because it's 2 minutes or less, giving you the basics of health insurance coverage.
Health insurance is designed to help you and your family cover the cost of your medical care, including doctor visits and prescription medicines. Similar to car insurance, you're responsible for paying a specific amount or premium each month whether or not you use any medical services. In return, your insurer will pay a portion of your medical costs should you or a family member get sick or injured. Keep in mind that your plan will likely require you to pay a portion of the expenses using your own money. These out-of-pocket costs may include a deductible, co-payments, and co-insurance. Now, a deductible is the amount you have to pay out of pocket before your plan will pay any expenses. This can include both medical and pharmacy expenses, meaning the deductible must be met before getting coverage for some or all prescriptions. So, for example, if your deductible is $1,000, your plan won't pay any of your healthcare costs until you've paid $1,000 in expenses out of pocket. Once you've met your deductible, you may still have to pay a certain amount out of pocket for services. One type of out-of-pocket cost is a co-payment or copay. This is a flat fee that you must pay for specific health-related services such as a visit to the ER for an injury, a trip to the doctor when you're sick, or picking up a prescription from the pharmacy. For some services or prescriptions, your insurance might require a different kind of out-of-pocket expense called co-insurance. Co-insurance means you must pay a percentage of total costs rather than a fixed dollar amount. So, for example, a medicine might require a 30% co-insurance. On a $1,000 medicine, you would have to pay $300. Because co-insurance is a percentage and can widely vary based on the cost of a service or product, it can be difficult to predict and plan for. All health insurance plans are different, so make sure you're aware of what you may have to pay to see your doctor or access the medicines you need.
Okay, guys. So, like I said, I like the video. It's really explanatory. 2 minutes or less, doesn't take up a lot of your time. I know sometimes through integrity recording like this, the video quality can come through a little strange, so I'll make sure to post this on D2L. So if you need to, make sure to go out and find the link on D2L. It'll be under the appropriate module for you to view. So we'll go ahead and work through reimbursement methods. This is where we're going to be talking about capitation. We're going to be talking about fee for service, things like that. So we'll get through this, and I'll go ahead and pause the video or stop the video rather, and then we'll pick up with part 2 for this. So generic reimbursement models, even though we have a wide array of different types of payers, we're really limited to the types of reimbursement methodologies that we go through with any type of health insurance payer. And these generally fall into 2 different types of categories. So we have fee for service, which is the traditional payment method that if you've been in healthcare, this is what you're used to, is going through fee for service. And this is just where your payment amount is tied to the amount of services provided. So you can be broken down to a couple of different categories here, like we have charge, cost, and prospective payment. But it's exactly what it's exactly what it sounds like. It's fee for service, tied to the amount of services overall that are provided. And then you have the other side of this, which is capitation. And this is a payment method that is based on the number of enrollees or the number of people covered in the population. So I have a couple examples, and we'll keep working through, but just know that these are the two broad categories when we talk about reimbursement that we're going to be referencing is the fee-for-service and then the capitation methods. So now that we know the two types of categories, we move into the three types of remuneration or money that we get paid to provide this service or the money that we get paid to work. And this is where it can kind of get a little confusing. So if you get confused, feel free to email me anytime, post it on the discussion board, shoot me an email, stop by my office, and we'll talk about it a little more. But just try to stay with me on the remuneration here. So we'll start with discounted fees. Exactly what it sounds like. It's in the fee-for-service spectrum, but you accept fees based on a discounted rate, and you take that discounted rate based on expected volume that you're going to get in. Salaries, you don't see this too often. I've never come across it in my experience, but salaries, that type of remuneration occurs when the provider, the physician, the nurse practitioner, whoever the provider is actually an employee of the managed care organization or of the healthcare or the health insurance organization. So they get a bonus for actually meeting enrollee usage benchmarks. So their incentive here is to really keep people out of services. They want to keep utilization very, very low because that cuts down on cost for the organization overall. So the incentive, like I said here, is to keep people out of services, and then the bonus for the provider is that they get a bonus if they have low utilization. The next one that we'll talk about, or the third type of remuneration, is going to be capitation. And this is, along with fee-for-service, this is the other one that most people are familiar with. This is based on a per member per month, or PMPM here. And again, remember, remuneration is that money that you get paid for a work or a service. So within capitation, we're working on a per member per month. So you're given a set amount as a provider every month, regardless of how your patients use your services. So my silly example I have here, I have Dr. Green. He has 500 patients. His median age of his patient population is 58. And then he has about 350 patients that have some type of chronic disease. So he gets $10 per member per month. So then we have his competitor, Dr. Red. He has 1,000 patients. His median age of his patient population is 27. And 100 of his patients have a chronic disease. So he gets $10 per member per month as well, just like Dr. Green. So you can see the different statistics for each physician. You have Dr. Green with his 500 patients, Dr. Red with his 1,000 patients. So if the two doctors, we know they're working on a per member per month basis, they each get $10 per member per month. How much money should they get per month? And I know this is really simplistic, but I'm hoping that it gets the point across of capitation and how it works. So Dr. Green, since he has 500 patients, he gets $10 per member per month. He's going to get $5,000 per month. Dr. Red, 1,000 patients times $10 per member. He's going to get $10,000 per month. So the provider incentive here under capitation is really to do some quality control initiatives, because what you want to do is make sure you address the problem correctly the first time, work out a good recovery plan or a good health plan out there, because you want to keep people out of the office so that you can keep and turn as much as this $5,000 or this $1,000 into revenue as possible. So as we look more into capitation, when we think about fee-for-service, the amount we get reimbursed is based on the number of services that we provide. So capitation is really the opposite side of that in terms of reimbursement. The the payment is not necessarily tied to the utilization, but the number of covered lives that we have. That's why it's based on a per member per month basis instead of utilization of services. And it's primarily used by, you see this more in your managed care type plans, and the most intense risk for the provider lies here with capitation, and works to shift risk from the insurance to the provider simply because now the provider's income, the provider's revenue is based on how often patients utilize services through their provider. So again, back to our example, 1,000 enrollees, $10 per member per month. We have $1,000 every month, which is the capitated or the fixed amount. You're not going to get any more. You're not going to get any less. This is the amount you're going to get every month through this managed care plan. So the incentive here is really for the provider to decrease the cost and decrease the utilization among his patients. Unfortunately, this has led to some different types of practice out in the healthcare field, particularly around telephone triage. If you've ever called into Nurse Call, I think is the one used for Mountain States Health Alliance, or NurseLink for Wellmont. They're going to ask you what's wrong over the phone to kind of triage you before you even come into the office to utilize any of the services, to see if coming into their office is the appropriate venue, or if you maybe need to seek some other type of care. It worked to really try and promote good health and patient education. But the most intensive risk, like I said, is here for the provider. And again, the incentive here is to keep costs low and keep utilization low. So then we move into talking about cost-based reimbursement. Again, this falls under fee-for-service. So cost-based reimbursement, under this model, cost-based reimbursement agreed to reimburse the provider or your physician for the cost of service. So really under this type of reimbursement, the physician has a relatively low risk. It's low risk for the physician, and the incentive here is to increase costs, simply because the more services you provide, the more reimbursement you're going to receive. When you think about more of your critical access hospitals, maybe more of those hospitals in rural areas providing services to really more of your remote populations, they continue to be reimbursed traditionally on a cost base, as opposed to more of your more metropolitan type areas. And again, the incentive here is to increase cost because you're getting reimbursed on what it cost you to provide the service, and the physician has relatively low risk under this model. So the next one we move into from cost-based reimbursement is your prospective payment. Go ahead and get all the details out here. So prospective payment, you have two different types under prospective payment. But the general background of prospective payment is your whole payment is determined beforehand. So this is where you get your pre-authorizations so that the insurance company can go ahead and get a good idea of what it's going to cost, and this is how much they're going to reimburse. So per diagnosis, or your diagnosis related group, your DRGs, is going to be dependent on your provider's the patient's diagnosis. So when you go in to see your provider, they're going to assign a DRG code to you, and we'll talk about that here in a couple slides when we talk about coding issues. But Medicare is going to pay the prospective payment by way of the DRG. That's where DRGs come from. They come from Centers for Medicare and Medicaid. This is all set up through them, and they pay on DRGs, or the diagnostic related group. So the DRG is going to work to tell the hospital how much it can expect for a certain type of disease classification and what that expected average length of stay or ALOS should be. So for example, let's say we have Mrs. Smith, and she's being admitted for a heart disease. Her case manager that's assigned to her when she's first admitted into the hospital is going to look up her DRG for her heart disease and see that her DRG is $10,000, or she's going to have 5 days of ALOS. So this means Mrs. Smith can either stay 5 days, or she can stay up till her bill costs $10,000 because the hospital is either going to be reimbursed for the 5 days of her treatment or the $10,000, whichever comes first. Now, when we talk about basing on procedure, this is per procedure, typically more for physicians. So really in this model, a separate payment is going to be made for each procedure that's performed on the patient, and it's more commonly used in your outpatient settings, your ambulatory care clinics. So DRGs you're going to find more in your inpatient setting. Think back to our Mrs. Smith example with her heart disease. And per procedure, you're going to see more on that outpatient ambulatory care setting. So still under prospective payment, where we determine the amount of payment beforehand, we have two other types that go along with the DRGs and per procedure. And those are per diem. Let's go ahead and get all the information out here. Those are per diem, and then your bundled or your global payments. We'll start with per diem or your per day. Per diem meaning per day, and this is where your facilities get paid a certain amount of money per day. So the incentive here is to increase your length of stay, because if you're getting paid a certain amount of money per day, you want patients in the hospital for as many days as you can keep them so that you can maximize your reimbursement. So again, incentive here is to increase your length of stay, but keep the costs low. So you really want to watch your service utilization if you're keeping them in the facility for a long time. So that leads to the risk that the cost, what it actually costs to take care of them, is going to exceed the per diem rate. So you want to make sure that the cost of care you're providing stays at or below that per diem rate, because, think back to what we talked about the first day. Hospitals are a business. They need money to run. So this is another decision they have to make in terms of making sure that the cost that they're expending on the patient is not going to exceed what the per diem rate is, or they'll be taking a loss on that patient. Now, global pricing, sometimes you'll hear this referred to as bundled payment. Sometimes you'll hear it referred to as global pricing, but they mean the same thing. And under global pricing, your reimbursement structure here is you have a defined set of procedures, and that's where we get the bundling from. So you have these procedures that are bundled together, and this is where your payment for a certain amount for certain services are really bundled together. So for example, let's say we have a patient who is pregnant and is going into the hospital to deliver. So that patient's charge for an OB delivery would include things like the hospital stay. You would have a charge for, the baby being there as a patient. You would have the OB charge. You would have the delivery charge, the pediatrician to come in and check on the baby charge. So the incentive here is to really control cost for the efficiency and work across all these different disciplines effectively. So you want communication and cooperation between the OB doctor, between the pediatric doctor, between the labor and delivery unit, because you're getting one bundled payment for this wide array of services, and now you're going to have to start splitting that payment out for all these different services, but you're getting one set amount given to you in this bundled payment method. So we've talked about cost-based, we've talked about prospective payment. The next thing that I want to talk about is charge-based reimbursement. And let's go ahead and get all the information out here. So charge-based reimbursement, is a type of reimbursement structure that's going to be based on the scheduled costs set by the providers. So the provider bills the payer or the insurance company for the full charges that the provider has set up in their charge structure, the full charges that the provider establishes for their services. So this system is similar to other systems where purchases people make, like groceries. So this practice of reimbursement was really seen more in the early days of health insurance, not so much today. And when you do see it today, you're talking more along the lines of discounting gross charges, which those discounts can range from about 20 to 50% or more. But again, this is very low risk for the physician because they can bill for the gross amount that it costs to provide these services, and then the payer would pay those gross charges. And again, this was used a lot in the early days of health insurance. You don't see it around too much more now. So just some things to think about. This is a question I normally go over in class, but think about the differences between all the different reimbursement methods we just discussed. And if you had to put yourself in the role of a CEO of a hospital, what is going to be your incentive in using each one of these different types of reimbursement methods? So if you have a discussion board and you'd like to go out and post your thoughts on the discussion board, I'd be very interested to see what you guys think in terms of what kind of method you would go with and why, or what your reasoning is behind that. So what I'm going to do is stop the video here because the next slide will be getting into managed care plans. So I think this will be a good end point. So this is going to end part 1. Make sure you pick up with part 2, and again, we'll pick up right here with managed care plans.